If you can't get enough supply chain, join us in Denver, June 5th through 7th for GS1 Connect, one of the leading supply chain conferences where you can connect with colleagues, interact with industry experts, tap into latest best practices, and discover how to use data most efficiently to optimize your operations and grow your business. Be one of our over 300 attending companies and engage with more than 100 speakers and over 20 trading partner roundtables to expand your knowledge on supply chain management best practices. Check out the agenda at gs1us.org to learn more about our keynote speakers and sessions. We hope to see you there.
Hello and welcome to the Next Level Supply Chain with GS1 US, a podcast in which we explore the mind-bending world of global supply chain, covering topics such as automation, innovation, unique identity, and more. I'm your co-host, Reed.
And I'm Liz.
And welcome to the show. Hello, everyone. I'm without my sidekick, Liz, today. She's traveling for business this week, but we do have two amazing guests. First, we have Kevin Capatch, who's the Director of Process Engineering for Geisinger, which is a regional health provider out of Pennsylvania. They service roughly 3 million people across 45 different counties in Pennsylvania. And then we have Vicky Lyle. She's the Vice President of Industry Relations for Owens and Minor. They're a global health logistics company with roughly 17,000 employees across 70 different countries. Today we talk about medical recalls, the current process, and where we are going in the future. There were some comparisons to the automotive industry and food industry, but they point out the specific challenges for healthcare. For example, medical devices are different from pharmaceutical drugs, and there are many different variables that need to be taken into consideration. And just 13 years ago, this recall management process was 100% manual. And today we're making great strides into automation, but we still have a lot more to do, and we need everyone involved. Please join us as Kevin and Vicki dive into the challenges of recalls. Oh yeah, you might hear them mention UDI throughout the conversation. UDI stands for Unique Device Identification. Kevin and Vicki will also be at Connect this June in Denver. So if you want to meet up with them live, make sure to join us there. Enjoy. Vicki and Kevin, welcome to the show.
Thank you.
Thanks, Reed. Really appreciate the invite.
We're happy to have you, and we have a lot to cover today, so I'm going to jump right into this. Can you tell us a little bit about your roles at Geisinger and Owens and Minor? And Vicki, why don't we start with you first?
Well, I'm the Vice President of Industry Associations at Owens and Minor, and I'm so fortunate to work with industry associations like GS1 and industry leaders like Kevin Capatch here, where we work on things like improving the healthcare supply chain. I've held many roles at Owens and Minor, including the development of our clinical inventory management solution called QSight. And that's really where my passion for getting the GS1 standards and UDI in place for our clinicians, because we really want to make it easy for the clinicians to capture the UDI with a one scan and take them out of the business of having to manually update their systems. So bottom line, that's really what we want to do, is try to make it easier for the clinicians.
Excellent. And Kevin, if you can just give your role.
Yeah, absolutely, Reed. I love what Vicki said about making it easier for the clinicians, because I consider my role as facing two directions, one inward and one outward. So inward wise, we're trying to support that frontline clinician. We know that technology is amazing today. The technology not supporting frontline can actually be distracting. So we work to make sure that the technology is value adding, whether it's making sure they have the right supplies or whether it's making sure they do their transactions easier into their EHR record. But the external world, that's where we focus on data standards to make sure that that technology does what it's supposed to do when they pick up the barcode scanner and hit that barcode for the first time. Because technically, Vicki knows this, we get about one shot. We don't get a good scan, then they're going to do a manual entry, and that's where things can go south in a hurry. But I love having the power of Geisinger behind me to help me drive data standards, because there's a few of us healthcare organizations that are really trying to prove this out so that others behind us can really benefit from it.
We're going to jump right in right now. So in today's world, we're constantly trying to improve our healthcare systems, specifically in areas like recall management. So can you talk to us just a little bit about what the recall management process looks like and the moves that are being made to improve the current processes?
What it looks like and what we'd like it to look like are two different things, right? What it looks like is really just an exercise in triggering as many people to do activities as possible. But unfortunately, what we need to do is trigger the right people to do the right activities. And fortunately, with some of the visibility systems we've worked on, like the Owens and Minor Q site, we can actually target recalls if the recall information contains specificity. So for example, if it just gives us a device identifier, then that's all I can match to, right? Then I have to put a bigger net out and cast it wider and pull all the devices. But if they give me a lot number, or they give me a serial number, or they give me an expiration date, then I can cast a smaller net and work a little bit more effectively. Unfortunately, without systems like that, when you get that recall notice, whether it's mailed in, whether you get it off a subscription service, whether you go to the FDA website and look it up yourself, it usually begins a very manual intensive process, Reed, where people just literally have to go out to shelves. It's what we call in the pharmacy speak, spin the bottle. You got to go touch the bottle, spin it around, see if you actually have the product. And then that triggers a whole escalation of whether you've got to notify the patient. But that's typically more detail in the recall notice itself. But it's a lot of manual effort today to process a recall in any health system, not just a Geisinger health system.
Kevin's absolutely right. There's still so many manual processes in place, and both Kevin and I participate on a ARM, or the American Hospital Association of Materials Managers. They have a learning UDI community, and we both participate in that community. And we did a study, I think it was in 2021. We took 6 recalls and looked at them and analyzed them and recognized that every recall is a little bit different. And the data elements even weren't consistent across all 6 of those. So of the 17 data elements that were required, only 8 of those were included in all 6 of the examples. And guess what? UDI wasn't one of them.
A lot of variety here. How does the use of standards aid in the process of improving recall management? Are there some areas where standards play a more importance role, or talk to us a little bit more about that?
Yeah, so the interesting thing about the recall process, when you look at it fundamentally, it's not a difficult process. It's an unfortunate process. You don't want to have recalls, but there are things that happen in healthcare that you need to make people aware of. So it's a simple process from the standpoint that I buy things and people make things. And if they tell me that something I bought needs to be recalled, that sounds very simple. But unfortunately, it gets back to what I said in the earlier comment. What are you telling me? If you're only telling me, did you buy this item, but you're not telling me when I was buying these items, or you didn't tell me with specificity which lot or which serial number or what the expiration date is, then it becomes this massive effort of overworking the system instead of targeting. And I think you'll hear a little bit later when we talk about the technology, how targeting is even possible today. But we're not there yet. I'm just saying we'd like to see it get there so that potentially someday, instead of reactive, it's proactive. You actually get a recall notice that says, we made this device, we shipped it to you. If you haven't put it in a patient, then you need to do these things.
Yeah. And for QSight anyway, what actually happens is when the clinician scans that barcode, and if it's GS1, it's one barcode. So they scan the barcode and they get the complete UDI. At that point, it's doing 3 different things. It's checking the product to make sure that if it is on recall, it's going to give the clinician a warning. If it's expired, it's going to give the clinician a warning. And at the same time, once that product's used, it's going to decrement the inventory. Or if there's a recall up front, it'll say, don't use this. And what's really nice is at that point, the clinician can make the decision. Ultimately, you want the UDI on the recall so that immediately when you get that notice, you can put the UDI into the system and it'll tell you everywhere where that product resides. And the goal is to get the product off the shelf before it ever enters the suite, right? You don't ever want it to go into the OR room. And if you have the UDI, it's a real easy, here's where all the product is. But even if it gets into that room for whatever reason, they didn't get the notice in time, or it was already in the room, when the clinician scans it, it should warn them. So that's the real beauty of UDI, because you can, to Kevin's point, be very specific on this piece of product is on recall and you should not use it. And that's what the UDI gives us versus just a catalog number that may or may not be on recall.
Yeah. And Kevin, when you don't get that specificity and you don't get that targeting, are you then just working at it at a macro level? Like, hey, we don't have enough information, so we have to take X number off the shelf or just discard or put off to the side. And there's got to be a lot of expense with that.
Well, that's truly, I guess, the reason why the ideal state would be so much more productive, right? Because if I pull a device that truly wasn't affected by the recall, but I don't have enough specificity that I have to set it aside, especially like what Vicky's saying, if I'm in the case and it flashes on the screen and says this product's on potential recall, well, I've got to come up with an alternate. That's not the best time to come up with an alternate to a device that you have ready to go into an OR or a cath lab or an IR procedure. So QSight actually works proactively to try to give us warnings. As soon as they pick up a recall notice, they scan inventory, right? They tell us that, hey, you have these products that could be effective, so that you could try to reschedule cases, or you could try to come up with alternatives to use during those cases prior to that event ever happening. But thank goodness QSight has that last defense in case all of our best efforts don't find that device that maybe got stuck behind something on a shelf. But at the end of the day, that's the wrong way to do this. These are medical devices that could be saving lives, and seconds matter. So you don't want expired product going into a case and causing a delay. You don't want a recalled product going to a case and causing a delay. I'm thinking back to 2010 before we installed QSight. And when I looked at how we managed inventory back in 2010, and that's only 13 years ago, at about the same amount of time when the FDA's law was getting ready to be issued, it was a manual system. I mean, you're literally talking a cath technician that would go into the closet at night after the cases and look to see what they wanted to reorder and try to check for expirations. And if he had time at the end of a very busy day, maybe to read through a stack of paper recall notices and try to determine whether or not they had any of those products. So when those things can happen automatically with a system supporting it, that's giving that frontline clinician, the best advantages we can do for today.
That was kind of my next question, and I think you really answered in that, but maybe we'll elaborate a little bit more. We were talking about process, and then I asked about the macro piece, but it's really managing recalled products is so important. You just talked about inventory counts, but are there other things that we're missing? Maybe we can just hover on this question here just for a second from both of you, if you don't mind.
I hinted to it, right? There's a patient-facing piece of this that requires somebody to read the recall notice if the device did travel through your care delivery system and understand, does that patient need to come in? Do we need to do something with the device? God forbid we have to do an explant and an implant of a different device. I mean, that's probably the worst thing that could happen with a recalled device. Other times you have to monitor to make sure the patient doesn't have potentially the ill effects that are described. But that can be interesting to go drill into a patient record, because you might find that if there's not specificity in the recall notice and specificity in the implant record, then you have to say, okay, people that had a hip implant from 2022 to 2023, that's a big macro sense that you'd have to go down through. But if you could get it down to, a lot of times, and I feel bad saying this, but because standards are at play here, we compare ourselves to the automotive industry. And somehow the automotive industry, with this magic thing called a VIN number, you can buy a used car and get a recall notice on a used car. You get a hip implant at a hospital system A and go to hospital system B for a treatment, and they haven't made their electronic health record portable, chances are you're in a blind situation again. So this is really a challenge for healthcare. I think when we solve this, it'll be something that the entire industry realizes that we've come full circle. We've got in the big leagues of doing recalls.
Capturing the UDI on the medical record is where we're going to protect the patient. When they scan it, it updates the EMR or the medical record. And to Kevin's point, eventually patients, and I think they can today, they do it in many ways is go out and look up their implant, and it's on the patient to see, if that product's on recall. But that's the important thing. It starts at the hospital, right? It starts where they have the procedure. And if they're capturing the information there, then it's going to be available for them throughout their life or throughout the life of their implant.
And there's also another slight piece to this that some of us that are really pushing the envelope are trying to drive towards, where if I can use the UDI in my medical record, and I can get the Mercies and the Mayos and the Intermountains who we've done research with, and they put it in their medical records, then we could find patterns in device outcomes much faster and be much more proactive even in that space to maybe prevent some of these recalls from occurring. So again, there's an ideal state that makes you, if you're involved in data standards, it makes you work that much harder, because it's like, we can get there. We aren't there, but we can get there. And we're starting to see evidence of it for those that are practicing. It's the three legs of the GS1 stool, right? Identify, capture, and share. Purely identify the product, capture the information, and then share it with the appropriate systems and partners. And you can really start to have an impact in an industry that, unfortunately, as early as 2009, when I started in my standards journey, for all intents and purposes, these were conversations. Nobody was even doing the capture at that point in time.
Well, and one of the beauties about a cloud-based system where we're capturing many hospitals into one system, today, even though the recall notices sometimes are still very manual, they come from multiple places. Maybe a customer may get the notification even before an update comes from another system. When we put that recall notice into QSight, it immediately informs all hospitals that is a recall, that this recall has occurred. And I think that's one of the beauties of sharing information around recall notices or even other product information that we can share.
Yeah, you guys hit two triggers for me. One with the car and the VIN example. My father is a truck driver and we worked on cars a lot, and I have a recall on one of my cars right now, and sometimes they're real and significant, and other times it's like, it's not a big deal. But then it was also the medical record, which a long time ago, patients really didn't have access to them. It was really more on the doctor side and the hospital side, but now you're seeing a lot more interaction. I mean, we just got a notice from our healthcare system here in North Carolina with a lot more access and more access to move between doctors and the system. Medical records, this going down on your permanent record, that just brought me back to grammar school and being in trouble. And, young man, if you don't correct your behavior, this is going to go down on your permanent record. But Kevin, you brought up identify, capture, and share, which is, a mantra here at GS1 US, identify things, capture that information, and then share it. Share it through the supply chain, share it with everybody that's involved. We know that standards can help improve and enable data quality, but how does improved data quality allow for more informed decisions at the point of scan?
One of the things that we're learning about QSight with the information we're capturing is we can start to do some case analytics. So behind the scenes, on the label, you're looking at the item identification information that you're trying to capture. You usually want the product number, you want the lot, the serial, the expiration, you might have a manufacturing code, but hanging on that item number typically are what we refer to in GS1 speak as master data elements that allow us to classify the items in a way that we can start to do some internal analytics and start to do some comparative analysis and say, well, who's having good outcomes with different products? So to get one step above the thing you have to be able to do, right? You have to be able to transact your inventory and respond to a recall or an expiration. But those are what I would call the basic blocking and tackling things that you must be able to perform as a healthcare provider. That's not the thing that gets the doctors excited. They like to see the patterns in the cases and the outcomes with the patient. Is a drug-eluting stent better than a non-drug-eluting stent? And if it is it in all classes and ages or all body types or gender types? That's where you can really enrich the information that these physicians are working with. And that's their power zone. We don't want them in the middle of a procedure worrying, am I using an expired device or am I using a recalled device? That's a supply chain support initiative. We need to make sure we've done everything to prevent them from ever being distracted from taking care of a patient. But we want to enable them to do that research and look deeply into their procedures and see, is there a difference in the products that I use? And I think we're just getting into that. I don't think we're setting the world on fire, but I think, again, we can see the ideal. We can see that coming as more and more people start to enrich their medical records with more than just that. Unfortunately, in some cases, most of what you saw out in research world was a charge code, which really takes you up a macro level, not to a catalog number. You're just looking at a charge code for a cardiac stent procedure, right?
Even across one health system, they've acquired hospitals through acquisitions. They're on different systems. Everybody kind of has their own codes for what products are, or supplies are, or implants are. And so everybody kind of has their own codes. And to do what Kevin's talking about, which is to do the comparison across not only the physicians in one hospital, but the physicians across their health system, oftentimes that's not easy because they're not all sharing the same information. So by using standards, it identifies that product and it allows us to do reporting across a health system or even across a market.
I'm so glad you brought that up, Vicky, because we talk about it in a lot of other industries, and I'm sure healthcare is the same way. This whole automation piece, you can't have automation without common context. I use a very, very simple example is when you see 03/02/2023 in the United States, we say it's March 2nd, 2023. But in England, they say it's the 3rd of February, 2023. It's the same numbers, but the context is different. And so when we try to get into these systems, you make a very good point. I mean, I've experienced it personally where we get an insurance bill and I'm like, what's going on here? Like, why did we get charged for this? And it's two different providers. There were two different systems, same type of doctor, second opinions and such, and we're getting billed differently, but we went and did the same thing. And so you're shedding some of the details behind the scenes as to what's really going on and the complexity of this. We often think like, oh, this is an easy system, do it like this. But there's always a lot more complexity to it.
I saw someone speak about standards, industry standards, and she was from the FDA, and she said there are 350 plus ways to spell BD, the manufacturer. And I just found that fascinating.
Wow.
So this is the power of standards.
And we're talking about Becton Dickinson?
Yes.
Right.
Wow. Okay. Well, let's talk a little bit about the future. How do you see recall management continuing to evolve and improve? And how will this provide even better patient safety, if it will at all?
When I wear my external hat, I actually have two sides to it. I have a DSCSA, Drug Supply Chain Security Act side, and I also have the UDI side. Because from a provider perspective, we look at it this way. We tell the story this way. It doesn't matter if I get the drug to the patient and I need a syringe. If the device doesn't show up, I still haven't completed care. And you can vice versa that, and it's the same effect. You got to get both there at the same time. So, when the FDA is regulating us and we're trying to meet these regulations with UDI and DSCSA, we've got to start to say, okay, let's look beyond regulations. I call that the stick view, like what happens if I don't comply? But what we're starting to say is, what happens if I do comply? What could happen that we couldn't do today because of compliance to these UDI and DSCSA laws? And I think this is where I'm getting really excited about the future, because in the Drug Supply Chain Security Act, not only is there something very equivalent at the point of capture, when the drug enters into the supply chain that you have to verify the pedigree, in the drug supply chain world, you actually are going to get a e-pedigree message that allows you to match up what was shipped to you and what you received. Now, in the medical device world right now, we still don't have that. We only are going to have the ability to capture the UDI at the threshold of receiving. But if you take that capture and you marry it up with information coming from the upstream partner, what we're calling the carrot in DSCSA is a targeted recall. We know we made this product. We know the channels it went through, because it's an e-pedigree trail, right? It's following this product the whole way through the trail, every trade. So you could theoretically, at some point in time, if you apply the logic, do a targeted recall. Reed, I know you got the product. Vicky, you didn't. And that could have an amazing impact on an industry where today, hey, Reed and Vicky, you might have got this product.
That's a lot of time and money.
That's a lot of time. So when you see things like that, you have to get excited, right? You have to go, wow, we got to go for the carrot, because the stick, yeah, we get it. It's a compliance thing. We want the drug supply chain to be safe and secure. But if we can get people excited because there's a benefit, and I think you could get every healthcare provider in the world excited about a targeted recall. You mean to tell me I don't have to see a notice unless they know I got the product? Drugs are heading there. There's already a grassroots effort working on that. Medical device is going to take some time, but the same EPCIS standard that's going to drive the e-pedigree in drugs is available to track anything in GS1 speak. I know over in the UK, they're tracking tobacco and they're tracking the batteries in EV vehicles, they're tracking firearms. So this is heading to a world where things could be done a lot more elegantly than it is today.
Yeah, you just crystallized that for me because I never thought about it. Right now, if I understand you correctly, Kevin, all healthcare organizations are getting a recall notice, whether they have the product or not. That's kind of like everybody in the United States is getting a recall notice for any type of car dealer or manufacturer. Even if they don't have a car, they're getting that notice, let alone it's not the kind of car that they drive.
Correct.
Well, think about the supply chain issues with that too, because they're putting all of that product on hold. And when they put it on hold to inspect it now manually by lot, serial number, it takes time. And they either have to order something in for their substitution and they have to do it immediately. So there's a huge supply chain issue with that as well, because to just put it all on hold, you're out of it. Now you got to figure out where to get it. We all saw that with the formula.
Exactly. And I'm so glad you brought that up because I was thinking in my head too, it's the cost of holding this. It's off to the side. It's taking up physical space. We need HVAC. We need electricity. Some things need to be kept at certain temperatures. Some things need other security parameters put around it, depending upon what the product is or the cost or if it's level of drug. And there's so many other things that we just take for granted in the supply chain. And it's like, okay, what's that building over there for? Well, that building's a significant expense. You got to pay taxes on that building. You got to pay electricity and all these other things. And it's just storage for us right now. Storage on things we can't even use. That makes no sense to me, but that's what's happening.
Right.
Wow. We're going to have to transition here. We're kind of running to the end of the show,
Okay.
but this has been amazing. And I know that both of you partake in GS1 Connect, which is our annual member conference. And for those that are going to be here, I encourage folks to seek you out and to continue these conversations because we all have to lean into this. We very much do. I want to end with our two questions. This is really kind of get to know each other a little bit questions. And it's also about just helping everyone expand beyond maybe some things that they know or don't know. But Vicky, I'm going to start with you first. Could be personal, could be work related, could be anything. But what's your favorite technology that you're using today?
Well, I'll tell you a technology that I'm starting to explore that I learned from my son. He's in college, but ChatGPT, which I know you hear it everywhere, right? But I've just started to use it to help me. You know, there's so much out on Google. You get every kind of answer that you want when you post a question, but ChatGPT sort of narrows the answer down for me, which is very helpful. So I've been using that a little bit.
Yeah, so you're using some AI. You have to check out Bard, B-A-R-D. That's Google's version of ChatGPT. There's some little differences behind them, but we're seeing that a lot. Kevin, what's your favorite technology you're using right now?
Yeah, so favorite buzzword technology, that's always a different question than favorite technology. And I kind of thought about my favorite technology to me right now. And I think we've quit talking about it, but it's the thing that's actually making us do the most incredible work today. And it's the internet. I mean, we are starting to solve problems today because we can connect and collaborate using this amazing process called the internet that didn't exist that long ago. And even when it did start to exist long ago, it was so poor. You were doing dial-up and listening to your modem ring in the background. People are like, modem, what's modem? So technology is amazing. There's always the new things coming, but we haven't even tapped the potential of the internet. today. We're just starting to get really, really good at using the internet. And I think when you talk about global standards, we're a 24/7 world. So I just heard one of my peers talking about an ERP upgrade, and the development team was offshore, but it gave them a 24-hour turnaround time because you could find the problem in Eastern time or Central time, have people working on it in India or somewhere else, and have the solution in the morning when you come back to work. That's going to get exciting because we're going to have a time compression we just haven't figured out how to tap into yet.
So Kevin, you kind of hit a near and dear thing to my heart, the internet, because way back in the early to mid 90s, I was working for Cisco Systems, the CISCO company. And my family and friends are like, what are you doing? And my dad goes, he sells woodworking stuff. And I'm like, what? Routers. I'm like, no, Dad, not a woodworking router. This is a technology packet transportation router. And that was the time when we had Banyan Vines, Apple Talk, Token Ring, Novell networks, and we talked about wide area networks and local area networks. And nobody talks about that anymore because it's just one ubiquitous internet. And it was built on standards. An IT stack layer of standards so that things can build off each other. All right. So my last question of the day, and Vicki, we'll come back to you again on this one to start, is what is something that's just blown your mind? It could have been when you were younger or in your young adult life, current life, whatever it is. And it doesn't have to be work related, but it can be, but just something that's like, you just stop. That's blown my mind. And you started looking at the world a bit differently.
I really think the world of AI is super exciting and scary in some ways, because even though we have this world of, my car can tell me that I'm going home every day, it's not always right. And I think that it's going to take us working with AI together collaboratively to answer the world's questions, right? And maybe that's part of the internet. It's part of things like ChatGPT, but we're going to be able to make better decisions going forward, I think, because of the massive amount of data that's out there today, and being able to take that and make it usable and actionable, which is something that we try to do with QSight already. But there's so much data that we all have, whether it's in our everyday lives or work lives, and taking that information and making better future decisions. That's what blows my mind.
Yeah, I would agree with you on that. Kevin?
My take's a little different. It's an aha moment that occurred back in 2011. I had spent many, many years professionally working in the manufacturing side of the world. And interesting that you speak about CISCO, Cisco, right? Cisco was one of my best customers at one point in time in my manufacturing career. And I was making the cable assemblies that were connecting your routers. And I just love the fact that your dad thought you were woodworking, because I'm sure some of the people in my manufacturing plant were wondering what a router was, because they came out of a cabinet industry up the road. But my aha moment in healthcare was the day that I realized, coming in 2008, 9, and 10, people were talking about healthcare being broken. And I had to open up a presentation. It was at UConnect. This is how old this was, right? This was before GS1 Connect. But I was invited to speak in a healthcare track down in Florida. There was going to be myself and 2 other GS1 people speaking. And I realized that I needed to get people's attention about data standards. And it wasn't a popular topic. Now, if you were in the retail side of the house at UConnect, it was a great topic, right? They've been using barcodes since 1974. If you're over in food, they're doing crazy stuff in food with doing recalls and tracking GPS location of the ship that caught the salmon that's on your table. So the weird thing was, I had read a book about doing a presentation, and it said, instead of end with a question, start with one. So I was mulling this over, like, what question would I ask that would capture people from the very beginning? And I realized, like 2 days before the conference, I never even told my speaking partner from Premier what I was going to say. But I opened up with this question, Reed. And this was my kind of epiphany question. I said, I can prove with one question that healthcare is not broken. Now, you think about that for a minute. All I've heard since I joined healthcare is broken. Healthcare is broken. We need to re-engineer healthcare, right? But I'm thinking about that, and I'm going, you know what? When was it fixed? So if you think about that, and you're talking about implementing data standards, you're starting at a point where other industries have been long past. They've built on data standards. This is a really important question. When was it fixed? And I'm not disrespecting healthcare, but this is a collegial process, a craftsman model, collegial process. We do brilliant things with devices. We make amazing devices, but the process of supporting those people are not as advanced as they could be. And I think that's where I get excited, because it's going to be a faster, rapid of implementation to catch that side up than it was to invent the ability to do neurosurgery in the way that we do neurosurgery today versus how they used to do it even 20 years ago. So I'm excited. There's no way not to be excited in healthcare, because it's the coming together of technologies and expertise. And end of the day, I mean, where else can you contribute to a process that you potentially yourself personally can't avoid taking advantage of? You have to get that into consideration, right? I made wonderful products for Cisco systems, Reed, but I never expected to buy them.
Right. Yeah, here you are. We're all going to use it. Wow, that was very profound. Well, that's all the time we have for today. I can't thank you both enough for a couple of things. One, just for your time today and your input. You've definitely blown my mind. You've expanded my thinking, and I hope that our listeners have found it the same way. But I also wanted to just personally thank you both for your involvement in the industry and for the work that you're both doing and that your companies are doing, because we all have to lean in. We're sitting here on a podcast. We're sitting in 3 different states. We're talking in real time with video. Those are standards from the IT side of the house. We talked about the car industry and VIN numbers, and we have to give ourselves some grace, but we have to keep pushing, because we're all going to be users of this, as Kevin, you just said. So thank you both for being on the show today.
Thank you so much for having us.
Yes, thank you so much, Reed, for the invite.
Thank you for joining the Next Level Supply Chain with GS1 US. If you enjoyed today's show, you can subscribe to our feed or explore more great episodes wherever you get your podcasts. Don't forget to share and follow us on social media. Thanks again, and we'll see you next time.